You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 12th, 2018. This week, aortic valve replacement, rivaroxaban, statins, conflict of interest, stent management, and a couple of feature articles. I want to first talk about a common scenario that you see often. The echocardiogram looks terrible. The aortic valve is calcified, a pinhole. The murmur is late peaking. S2 is soft. But the patient says, I feel fine. No, I am not short of breath. I can even still walk the golf course. You're tempted to refer for aortic valve replacement to replace the severely stenotic aortic valve. But the old teaching says, wait for the patient to become symptomatic. The big three, angina, heart failure, or syncope. Now that we have tools for early intervention, say TAVR, there is an urge to refer earlier for aortic valve replacement. The most recently published paper, in JAMA no less, suggests benefit from early referral. But my friend, journalist Steve Stiles, is such a wily writer of news. He gives away the problem with the paper in the first 4 words of his story. Here's the quote. A cohort study supports. Boom, there you go. In 4 words, you know not to make the leap to the conclusion that earlier aortic valve replacement produces benefit. Cohort studies are not RCTs, so you can't make these sorts of causal claims. In this non-controlled, non-randomized analysis, a group of authors so large you would think it's a genetic study merged data from institutional databases from heart clinics the world over. And they found that patients with severe AS at baseline and peak velocities of 5 meters per second or greater, or ejection fractions less than 60%, have an increased risk of all-cause and cardiovascular mortality even after aortic valve replacement. And they say, quote, the potential benefit of early intervention should be considered in these high-risk patients. To be fair, the authors are careful with their words, as were the editorialists, but these sorts of analyses should not be used to change guidelines on the timing of AVR. The way to answer this question is so easy. You randomize patients with severe symptomatic aortic stenosis to aortic valve replacement or medical management. We've been doing AVR for decades, and it shocks me that such an important question remains unstudied. One thing I did learn from the news piece is that an early intervention TAVR study is being planned and in its early stages, which is a good thing. The next topic is on rivaroxaban. It's normal to use an antithrombotic drug after TAVR. So essentially, the Galileo trial compared rivaroxaban against antiplatelet drug therapy after successful TAVR. But the Data Safety Monitoring Board recommended stopping the trial due to higher rates of the primary outcome and bleeding in the rivaroxaban arm. Listen to these numbers. The primary endpoint, death or stroke, occurred in 11.4% of the rivaroxaban group versus 8.8% in the antiplatelet arm. The primary safety outcome of bleeding, 4.2% rivaroxaban, 2.4% antiplatelet, so almost double. And all-cause death rates were also higher, more than double with rivaroxaban, 6.8% versus 3.3% with antiplatelets. Now, of course, trial results that are come from trials that are stopped prematurely don't tell the whole story, but these are strikingly poor data for rivaroxaban. Surely we will want to avoid rivaroxaban for preventive means after TAVR. Now, one issue that comes up here is that rivaroxaban is commonly used in patients with AF and surgically placed bioprosthetic valves. This is based on post-hoc analyses from the DOAC trials. And will this finding from the Galileo trial influence these common practices now? This rivaroxaban failure comes on the heels of the failure of the Navigate ESIS trial this summer. Navigate ESIS was an RCT looking at rivaroxaban versus aspirin for the prevention of recurrent stroke after embolic stroke of unknown origin, in which rivaroxaban was found not superior in efficacy and associated with more bleeding. Now, I'm not sure what, if any, global conclusions can be made about rivaroxaban, but this really gives one pause about the drug. Stay tuned for more on this story. What would a podcast be if we didn't talk about statins? Thousands of patients have been enrolled in clinical trials, and it is clear that statin drugs reduce cardiovascular outcomes. But there have also been hundreds of studies looking at statin efficacy for non-cardiovascular outcomes. Recently, a group of authors publishing in the Annals of Internal Medicine performed a meta-analysis of hundreds of studies, including other meta-analyses that studied statins for non-cardiovascular outcomes. This is a short story. They found no evidence that statins improve non-cardiovascular outcomes. Another finding and confirmation of previous studies that they did report is that when they looked only at RCTs, the authors found no statistically significant effects of statins on myopathy, myalgia, and rhabdomyolysis, which is similar to the statin trials in cardiovascular disease. So the bottom line here is simple. Use statins to reduce outcomes from heart disease, but not for anything else. Next topic is industry ties with practicing doctors. Dr. Aaron Kesselheim and colleagues from the Program on Regulation, Therapeutics, and Law at Brigham and Women's Hospital, Harvard Medical School, set out to study industry ties in the real world with practicing doctors. The study involved a sample of about 1,500 doctors, internists, endocrinologists, and cardiologists. And they found that almost 3/4 of docs report ties to prescription drug or device companies. Most often it is in the form of free samples or free lunch or free beverages in the workplace. Smaller percentages of docs report fees for consulting, speaking, or serving on a scientific board. Now, I feel strongly about this topic. We have no need for company reps in doctors' offices, period. On the matter of free samples, I cite my grandfather's wisdom, who said, "There's never a free lunch." This is all pure marketing, and for patients, free samples only delays the inevitable cost issues. On the matter of bringing lunch and beverages, this is also marketing. One purpose is to increase face time with docs. Another purpose is to induce a feeling of gratitude for taking care of the office staff. And finally, obviously, it's to promote a one-sided view of their product. In 2018, a clinician can access less biased medical information, drug information in seconds on a smartphone. I've been trying unsuccessfully for years to get drug and device reps out of our hospital. And to those who say they are not influenced by lunches and coffee, I respond by saying that if these techniques did not influence you, the companies would not use them. I say, eyes open, colleagues. Now let's talk post-stent management. Another common scenario is when a patient with atrial fibrillation and risk factors is taking an anticoagulant and is on an antiplatelet because she had a PCI and stent more than a year ago. And my question is always, can I drop the antiplatelet drug now that it's been more than a year? So we don't want patients to have stent thrombosis, but we also know dual therapy with anticoagulants and antiplatelets increases the risk for bleeding. Well, Japanese authors set out to answer this question with an RCT enrolling patients with AF who had a stent more than a year ago, to double therapy, oral anticoagulation plus antiplatelets versus oral anticoagulants alone. This is a really good question. Circulation published the non-inferiority trial, which was also presented at TCT. Primary endpoint was a composite of death, MI, stroke, or systemic embolism. They aimed to enroll more than 1,000 patients, but only were able to get 696 patients. And the primary endpoint occurred in 15.7% of the oral anticoagulant alone group and 13.6% in the oral anticoagulant plus antiplatelet group. And so the point estimate of the hazard ratio was 1.16, but the upper limit of the credible interval was 1.72, and that exceeded the pre-specified non-inferiority margin of 1.5. So oral anticoagulant therapy alone did not meet non-inferiority. But the big problem, the core problem, was that the trial was underpowered because of low enrollment. Without enough events or patients, we can't say whether the failure to meet non-inferiority occurred because oral anticoagulation alone was not as good as both drugs together, or it was just a play of chance. And the authors note that difficulty in patient enrollment mainly stemmed from reluctance of cardiologists to withdraw antiplatelet therapy in stented patients. Now, this is a huge problem with all clinical trials. If doctors believe something is effective, they are reluctant to enroll. But I think we should be able to keep an open mind when RCT data is either unavailable or outdated. Before this trial was presented and published, I had not realized how little evidence we have guiding us after the first few months after stent placement. I think trials of dropping medicines after a period of time, so-called deprescribing, seem more relevant than ever. But for now, we have to accept the uncertainty in the use of dual therapy with oral anticoagulants and antiplatelets after PCI. And if you have any ideas on this problem, feel free to leave a comment. I wanted to point you to a notable feature article published last week from Dr. Melissa Walton-Shirley. I call her MWS, and her description of bidding adieu to full-time cardiology practices is poignant. Indeed, it evokes a keen sense of sadness. Now, there are doctors, and then there are clinical forces of nature. Melissa Walton-Shirley is a force of nature. She fearlessly pursues what is right. For instance, she alone worked to get smoking banned in public places in her hometown, years before it was fashionable, and her hometown is in Kentucky, the United States' largest producer of tobacco. And at international meetings, you see Dr. Walton-Shirley talking with patients and families on her phone. She's answering Facebook messages. I don't think I've ever seen her on a true holiday. Then there are the press conferences. You know, the truth is, I've never had the guts to confront a PI with a question in a press conference, but not Melissa Walton-Shirley. She's often asking the first question. She's strong, clear, completely and utterly comfortable in her own skin. Yep, she is definitely a force of nature, and her essay is worth a look. Finally, I wanted to say a word about my trip to Poland last week, and that's why I missed the last week's podcast. I had the pleasure of serving as faculty at the 13th PQRST Subcarpathian Heart Rhythm course in Rzeszów, Poland last weekend. And a couple of comments. First, this came about because I became friends with electrophysiologist Peter Futima. Now, why or how did an EP from Kentucky, USA, become friends with an EP from southern Poland? It's because we interacted on social media. Then we met in real life multiple times and became friends. Now we are even writing academically together. My friends, I know social media has its challenges, but connecting people all over the world is a beautiful thing. Now, the second thing is, after our lectures on Friday in Poland, I watched their EP team work on Saturday. St. Joseph's Heart Center has one EP lab. It's a small private hospital. They did 9 cases, 4 pacemakers, 4 ablations, and 1 coronary angiogram. The rigor of the EP was incredible. The efficiency of the room turnover was amazing. Lack of burdensome EHR helped tremendously, and so did the buy-in of the staff. You could tell they've been working together for a long time. Now, Polish electrophysiology differs from American EP in that the procedures are bundled, meaning they get one price, one reimbursement for an AF ablation. So this means that procedures in Poland are done with minimal waste. And American EPs might be shocked to learn that AF ablation can be done safely and skillfully with far fewer of the extras that we deem necessary here. And American patients might be shocked to know that you can do many of these EP procedures, such as pacemaker generator changes, with less or no sedation and much faster recovery. In fact, I saw patients just get up and walk out of the room in Poland. I also learned that the Polish government, the payer, puts a yearly cap on elective procedures done at each hospital. Now, while there is no limit on how many STEMIs one can do, there is a limit on how many AF ablations or SVT ablations you can do. Now, I know Americans may bristle at this, but it forces doctors to make wise decisions. It discourages waste, and it also confronts a reality Americans hardly ever confront, namely that there is a limit to what can be spent on healthcare. Finally, I want to close by thanking my Polish hosts for their warmth and generosity and kindness, and for teaching this old American doctor many, many useful lessons. Thank you. And that's it for this week in cardiology. I'm grateful that you listened. And remember, if you like this podcast, please consider subscribing and leaving a review. It really helps other people find it.
You're listening to This Week in Cardiology from theheart.org on Medscape.